I am excited to be here today to share with you a little bit about what I have learned about cultural competency and critical care. My conflicts include that I'm a director of the American Board of Anesthesiology. I serve as the ASA liaison to the American Heart Association, and I'm on the medical advisory board for a company called Vise Medical. Today, I'd like us to reflect on cultural competency in the context of how we interact with other members of our healthcare team and how we treat our patients. We'll take a closer look at the concept of cultural humility, debiasing, hidden hypoxemia, and psychological safety. Let's start out with a formal definition of culture by the father of organizational psychology, Ed Schein. Culture can be defined as a pattern of basic assumptions invented, discovered, or developed by a given group as it learns to cope with its problems of external adaptation and internal integration that has worked well enough to be considered valid and therefore is taught to new members as the correct way to perceive, think, and feel in relations to those problems. Some have taken this formal definition and simplified it to culture is really what happens when no one is looking. Cultural competency in healthcare describes the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including the tailoring of healthcare delivery to meet patients' social, cultural, and linguistic needs. Conventional wisdom is that your organization and your ICU embraces cultural competency if you have language services and have an education program on how different racial, ethnic, or religious values or traditions impact healthcare delivery. Simply put, this is really a checklist model with an end game. But I'd like to challenge conventional wisdom. And so I have two questions that I want to propose. What if being culturally competent isn't possible? And what if there is no end game? I know I'm a work in progress, and shifting my mental model from cultural competency to cultural humility recognizes that I may not know what I think I know. Because cultural competency can create a false sense of understanding of an identity group, perpetuate biases, and promote stereotypes. Cultural humility recognizes the limits of people's knowledge of others. It also acknowledges that even people who have cultivated their cultural awareness can still have unintentional, unconscious biases about cultures other than their own. In comparisons of cultural competency and cultural humility emphasizes individual traits, combinations of cultures, promotion of respect, flexibility, and embraces a lifelong process of learning. And the first step in cultural humility is really about knowing yourself. When we bring ourselves to an ICU or any organization, individual factors such as cognitive biases and how we think affect our medical decision-making. Cognitive bias is a distortion in judgment and decision-making. With cognitive biases, we may try to confirm our existing beliefs or forget something that actually happened. Simply put, our cognitive bias is our blind spot. And with this blind spot, we may miss an elephant in the room. Anchoring is an example of a cognitive bias. When we anchor, we lock onto a feature of an initial presentation and then don't let go of that feature as we learn new information. For example, a patient with sickle cell disease may present with tachypnea, and we may attribute her respiratory rate to anxiety. If we learn that these symptoms are similar to previous admissions for atypical pneumonia, we begin to anchor if we don't consider the possibility of acute chest syndrome. Availability bias is a second example of a cognitive bias. In this case, the clinician may recall a particularly dramatic case that's imprinted in his or her memory and readily available, and the clinician may quickly conclude that another patient's presentation corresponds to a case that the clinician had encountered in the past. Attribution bias is a third type of cognitive bias. An attribution error arises from a stereotype. In this situation, the clinician may fail to consider that the stereotype may be misleading. A patient with a history of IV drug abuse who presents with abdominal pain may be considered a drug seeker rather than a patient who has an abdominal aneurysm. Astoundingly, there are almost 200 known biases in existence. While we may think that our decisions are rational, think of these biases as blind spots that can interfere with decision-making and lead us down an irrational path. Each of us has the potential to bring our own unique cognitive biases to the ICU. Researchers in decision-making call efforts to reduce these cognitive biases cognitive debiasing. And familiarizing yourself with some of these biases is a good first step to avoiding them. Familiarizing is a debiasing technique that you can use immediately. It's important to distinguish implicit or unconscious bias from explicit bias, which can be racism, sexism, and homophobia. Although a person can have both explicit and implicit negative biases about a certain group, it's possible to consciously be egalitarian in one's view while holding negative, implicit biases about certain groups. This is the inconvenient truth about implicit bias. Good people can unknowingly discriminate. One common measure of implicit bias is the online implicit association test. It's a collaborative effort between researchers at Harvard University, the University of Washington, and the University of Virginia. And several studies have shown that these tests are correlated with bias in clinical decision-making or patient perception of their providers. Here are 3 such studies that suggest that the performance on an implicit bias test was associated with communication ratings, thrombolytic decisions, and pain management. Now, I recognize that these studies may feel controversial, but our challenge in medicine and in the academic pursuit is to be curious about any discomfort that we feel. A 2016 survey of a little over 200 medical students and residents was published in the Proceedings of the National Academy of Sciences, and it showed that half of them endorsed at least one myth about physiologic differences between Black people and white people, including that Black people's nerve endings are less sensitive than white people's. When asked to imagine how much pain white or Black patients experienced in hypothetical situations, the medical students and residents insisted that Black people felt less pain. This made the providers less likely to recommend appropriate treatment. A third of these doctors also believed that Black skin is thicker than white skin. This survey was done in 2016. From survey to reality, we learn in this study of a large national database in the emergency room setting of approximately 1 million children that Black children are less likely to receive pain medication for moderate pain and less likely to receive opioids for severe pain in the setting of appendicitis. This meta-analysis found that among adults, Black patients and Hispanics were less likely to receive analgesia for acute pain in the emergency department. So I want to pause for a moment and think about the concept of a mental model. A mental model is an understanding of the situation in front of us. the tasks that need to be done, and the resources available. I'm reminded of a short story that was told to me in medical school that illustrates the lack of a shared mental model. A woman driver comes racing round a corner, barely in control. "Pig," she shouts at a man driving the other way. "You're a pig," he shouts back. The man rounds the corner, hits a pig, and dies. If we don't share the same mental model, despite our best intentions, accidents can happen. Watch this video on teamwork and trust and imagine what would have needed to have been communicated to prevent what you have.
And it'll be an exercise in building trust between one another. So Harrison, if you don't mind going first, step up here on this chair and close your eyes. All right, and then everybody fill in. And we're going to ask you to fall, and then they will catch you. So you have to trust us. So I'm going to count to 3. Just relax and fall. Okay? 1, 2, 3. No, wait, no!
In this slide, some people see a young woman with her head turned towards the background, while others see an elderly woman's side profile. A 2018 Australian study found that who you are affects what you see. Younger participants saw the young woman, while older participants saw the elderly woman. What do you see in this picture? It depends. You may see a duck, or you may see a rabbit. The duck's beak are also the rabbit's ears. So let's take a few moments to be curious and humble in our understanding of mental models in critical care. This study of ICU patients found that the color of your skin affects your pulse oximetry reading. For patients with a pulse oximeter reading of 92 to 96%, an ABG saturation of less than 88% was found in 3.6% of white patients and 11.7% of Black patients. Black patients had nearly 3 times the frequency of occult hypoxemia that was not detected by pulse oximetry as white patients. These results suggest that reliance on pulse oximetry to triage patients and adjust supplemental oxygen levels may place Black patients at increased risk for hypoxemia. In this analysis of critically ill patients, hidden hypoxemia was found in all groups, but most commonly among Blacks, and was associated with greater organ dysfunction and higher in-hospital mortality. Years ago, when GFR was directly measured, there was a difference in GFR measurements between Black and non-Black persons. That observation led to incorporation of a race coefficient in estimating equations that would inflate GFR estimates for Black patients. The use of a race coefficient is estimated in glomerular filtration rate equations, and this can perpetuate health inequities for Black individuals with kidney disease. In an effort to rethink GFR, national organizations have recommended removing the race variable from equations and to encourage efforts to use cystatin C in clinical decision-making. So I'd like to offer a perspective on cultural competency and humility through the lens of teamwork, and suggest to you that how we create cultural humility in critical care is similar to how we can create the ideal team. In healthcare, we often have to work with unfamiliar team members at a moment's notice. To prepare for a crisis in an ICU, we would need to be able to answer a question of who would you want on your team, especially if team members did not know each other. And many of us have heard the expression that there is no I in team. And I think this concept is an important one as we try to figure out what makes the perfect team. We need to remember that our team in the ICU, regardless of background, will be part of an unpredictable environment that's complex and adaptive. So let's imagine for a moment that we could choose anyone at all to be a part of our perfect team in a crisis. Who would we pick? Would we pick someone who's intelligent with a high IQ? Would we pick someone who's motivated? Would we pick someone who's extroverted? Would we pick someone with experience? Or would we pick people who always work together? So Google wanted to investigate this question. In their quest to build the perfect team, they began to study why certain teams were more successful than others. And what they realized is that the who didn't matter. It didn't matter how smart you were. It didn't matter how much experience you had or the source of your motivation. What mattered is how team members treated each other. And Google found that good teams do two things. Number one, members speak in roughly the same proportion of time. There's an equality in the distribution of conversation turn-taking. Simply put, one person doesn't dominate the conversation. And number two, good teams have high social sensitivity. In other words, team members are able to tell how other members feel by the tone of their voice, facial expressions, and other nonverbal cues. Together, equal conversation and social sensitivity equals psychological safety. More formally, psychological safety was coined in 1999 by Amy Edmondson as a team climate characterized by interpersonal trust and mutual respect in which people are comfortable being themselves. I believe that having high social sensitivity facilitates our ability to know the skills, to know the weaknesses, and to know the strengths of unfamiliar team members. Knowing your team is also about being curious about team members, and this requires direct and clear language. Well, in the ICU, our team also includes the patient. And having a sense of curiosity applies to how we treat each other, our patients, and their families. Humility is about creating the conditions of psychological safety so that everyone, including our patients, is comfortable being themselves.
Good afternoon. The topic of my talk will be on situations in which cultural competency can prevent conflict in the ICU. My name is Linda Liu. I am the Vice Chair for Quality and Safety at UC San Francisco. I have no financial relationships to disclose, and my presentation does not include off-label drug use. Communication is incredibly challenging in the ICU due to a variety of factors. Patient acuity forces us to communicate while the patient is physiologically unstable, imposing time constraints to the information that must be conveyed. The uncertainty of the diagnosis or prognosis adds a layer of difficulty to the communications. And there are ethical challenges, such as using advanced treatment options in scenarios where survival is poor. Once the acute event has stabilized, the long-term communication in the ICU is often challenged by our work shifts, whether it be transitions from day shift to night shift or from one week to the next. Attending physician A may be a wonderful communicator, helping to prepare the family for a poor outcome, whereas attending physician B has different opinions about the patient's prognosis and resists directly engaging with the family. The ICU is the antithesis of an environment conducive to dealing with complex life and death decisions. Studies show that families are more dissatisfied with communication in the ICU than with any other care issues. We're going to take the next 15 minutes to look at some opportunities to decrease conflict and miscommunications by being culturally sensitive. What is cultural competence? Cultural competence is not just about learning a bunch of stereotypes to expect from other cultures. Cultural competence requires reflection, practice, and awareness regarding our own values, attitudes, and perspectives. We assume that our ethnic group is representative of everything that is proper in life, and we conclude that our values, norms, and behaviors are universally understood. Cultural respect is a commitment to understanding the patient's health in context through their lens. Be aware that there can be a thin line between the activation of cultural knowledge versus the use of stereotypes. There is diversity within cultural groups, and each person is a unique individual, and his or her behavior is influenced by factors other than culture alone. It may make intuitive sense to caution against overgeneralizing cultural differences when interacting with minority group patients, but unconscious bias is just that. It's unconscious unless we specifically are vigilant for it. Unconscious bias occurs when a person without thinking classifies a patient as a member of a group and applies stereotypical characterizations of the group to the individual. Let's start with our first case example. We have an 88-year-old woman with a large family who presents the ICU with end-stage ovarian cancer. Multiple family members were congregating in the ICU and the family waiting room. While the family spokesperson was her eldest son, the patient also had her husband, 3 daughters, and multiple siblings. There were disagreements in terms of how much of the diagnosis was to be told to the patient, and while this occurred pre-COVID visitor regulations, there was conflict with the ICU staff in terms of the number of people coming and going, and conflict with other patient families due to limited space in the waiting room. One particular area to note is nonverbal behaviors. Nonverbal behavior accounts for 60 to 90% of communication. There are nonverbal practices that appear to be accepted across cultures, such as open body position and demonstrations of warmth by facial expression. There are also reports of nonverbal behaviors that convey culturally different meanings, such as directness of eye contact and meaning of hand gestures or touch. In the U.S., eye contact is expected when we engage in conversation and is a signal that the person is listening. In other cultures, maintaining direct eye contact may be considered confrontational when speaking to authority figures. Direct eye contact is reserved for peers. COVID has enormously affected how we interact with patients given PPE requirements. Many hospital providers use large head and shoulder pictures so that patients can see the provider's full face, but a lot of cues, such as facial expression, that we use in nonverbal behavior are nullified. Patient control and autonomy are core values in Western bioethics and important components of end-of-life care. American healthcare puts a great deal of emphasis on patient autonomy and the patient's right to know. This attitude is not shared by all cultures, however. There are significant cultural variations in the willingness to talk about and plan for death. Some cultures often deem the Western healthcare system to be hurtful in its direct and truthful approach to death and dying. They believe that talking openly about death and dying will bring sadness and may even accelerate dying. They protect family members from their terminal prognosis, believing that the truth is too painful. Many cultures have a family identity as primary and the individual as secondary. There can be many people who are all considered part of the family. Decisions on end-of-life care tend to be made through family consensus, with the father or oldest male serving as the family spokesperson. Some things to consider in this case. If possible, have conversations with the patient regarding the role she would like her family to play in her care. Allow patients to decide who is considered a member of their family. Actively engage family members and allow the family to be involved in the care of their dying loved one. Identify the spokesperson for the family and communicate any changes or needs. While maintaining open communication with the family spokesperson, it is also important to make time to meet with the whole family to understand questions or address concerns. Plan to have a formal multidisciplinary family meeting within 3 to 5 days of an ICU admission, and then every 3 to 5 days thereafter to improve communication about goals of care. Involve the chaplain, social worker, palliative care teams, or other resources sooner rather than later. They can help clarify goals of care and deliver a consistent message. Meetings with a large number of people have also been difficult with COVID. Over the past few years, we have tried to have family Zoom sessions, but sometimes in multi-generational, multilingual families, there are limitations with technology. During these meetings, providers should try to manage differing family members' opinions, agendas, ways of coping, and emotions, while maintaining a relationship with the family unit as a whole. It may also be necessary to designate a space, perhaps off-campus grounds, where family members can congregate. This will facilitate adherence to institutional policy regarding number of visitors allowed. Prior to COVID, open visitation or have family visitation during rounds helped improve communication. In summary, remember that everyone may come to a clinical interaction with their own biases. By standardizing cultural variables just to race and appearance, we ignore other important key factors such as socioeconomic status, religion, trust, and education. Prejudices and stereotypes can be diminished when people are perceived more in terms of their particular qualities than primarily as members of a particular culture. The key relationship is to demonstrate respect and empathy, build trust, use culture-specific knowledge as a basis for beginning exploration of individual or family beliefs. I wanted to touch next on the topic of religion, which plays a large role in many cultures. Some families believe that all life is sacred, no matter the quality. They believe that intensive care should not be stopped due to an expectation of divine intervention and complete cure. They also may have a conviction that overly pessimistic medical predictions are wrong, or they reject intentional shortening of life by withdrawing or withholding therapy. This leads to a lot of stress and conflict for the physician and nursing teams who feel often that we are harming the patient and causing pain for no significant benefit. Often, intensivists struggle with the idea that we can, but should we? So here is case number 2. We had a 60-year-old woman who was a Jehovah's Witness admitted to the ICU with acute liver failure after ingesting toxic mushrooms. Her admission laboratory values were an INR of 4, platelet count of 145,000, and a hemoglobin of 11. Prior to the onset of encephalopathy, there was extensive dialogue among the providers, family, and patient regarding what she would accept. Fortunately, the patient could still participate, but it was a non-English speaking family requiring the use of an interpreter. This patient explicitly refused packed red blood cells, platelets, fresh frozen plasma, and cryoprecipitate. She did accept prothrombin complex concentrate and fibrinogen concentrate. She also accepted erythropoietin and thrombopoietin receptor agonists, as well as continuous intraoperative cell salvage. Unfortunately, her acute liver failure worsened. She developed cerebral edema and required intubation for airway protection. Her hemoglobin dropped to 8 milligrams per deciliter, platelet count was 35,000, and her INR was maintained around 2.8 with frequent prothrombin complex concentrate boluses. Now a liver donor is available. I'm going to leave the case because there are clearly many possible endings, but mainly I wanted to use it as a segue to a discussion about religion. In terms of religious communications, it's best to respect the family's religious preferences, which may include rituals, prayers, and beliefs. We have allowed music, prayers, chanting, and alternative remedies. If the practice is not harmful or counterproductive with the traditional healthcare method and ICU policies, then consider including it in the care plan. In matters of religious preferences, it can be helpful to engage the assistance of religious community leaders, priests, ministers, and rabbis. They may aid in understanding the application of the religious principles to the situation. The last cultural distinction to emphasize is language differences, which are probably the single most important obstacle to providing culturally relevant health care. Most interpretation companies offer 150 to 170 languages. There are over 6,000 recognized languages in the world, although this number is decreasing over time. We know that there are at least 329 actively used languages in the United States, which means we do not have interpreters available for all the possible languages needed. If an interpreter is available, what do we know about their accuracy? In a study from the emergency department, the researchers analyzed 57 audio-taped encounters to compare the accuracy of translation by 3 means: professional interpreters, ad hoc interpreters such as family or staff members, and no interpreter, when patient and physicians use no assistance. They found that interpretation errors of potential clinical importance were common, peaking as high as 22% when we used no or ad hoc interpreters. Professional interpretation had roughly half as many errors at 12%. One of the best case studies of communications lost in translation was described in his book published in 1997 titled "The Spirit Catches You and You Fall Down." If you haven't read it before, it is well worth the time. The book tells the story of a Hmong family and their interaction with the medical community when their daughter was diagnosed with a severe form of epilepsy. The hospital in the Central Valley of California at that time had no Hmong interpreters, and when interpreters were found, there was no Hmong equivalent for the word epilepsy. It literally becomes, "The spirit catches you and you fall down" in Hmong. This spiraled to a tragic cultural conflict, and the difficulty with communication that obstructed her treatment even led to the child being placed in foster care for a year. When she was transferred to Fresno for a higher level of care, the parents thought that the physicians were going on vacation. Ultimately, through a series of miscommunications and misunderstandings, the patient lapsed into a coma at the age of 4. She lived in a persistent vegetative state for another 26 years and passed away in 2012 at the age of 30. Clearly, the first difficulty between languages is that sometimes the actual translations are not available. The Hmong do not have a word for seizures. Other languages do not have a word for diabetes, or the word for a complex medical procedure does not exist. The cat in the cartoon does not have a word for fetch. Concepts lost in translation are also prominent. This study looked at 10 ICU family conferences in 2 Seattle area hospitals using in-person interpreters. Alterations occurred in over 50% of the interpreted speech passages. 77% were rated as significant alterations. Of the alterations, 93% were rated as having a negative effect to the common goal. What was most concerning was that alterations potentially affecting treatment decisions occurred on average 16 times during each conference. In the study of pediatric critical care family meetings, the number of alterations rises proportionally with the number of words spoken by the clinician per utterance. Out to the right of the curve, at over 60 to 80 words, there was an average of 1 to 1.5 alterations made by the interpreter. With shorter remarks, there were lower number of alterations. Errors were lower on the left, with minimal alterations below 17 words per remark. One attempt to improve communication is offering printed information that orients the family to the ICU in multiple languages. Written materials are helpful for people who read and comprehend at the level at which the materials are written. But do people really take the time to read the documents in times of critical illness? And what about families with low language literacy? Implementing remote video interpretation services have lessened the barriers to interpreter use. They have provided a good alternative or supplement to in-person interpreters. Currently, there is no clear data on whether video versus in-person interpretation is more accurate, but we know both are better than no interpretation. Some thoughts to help with language differences. Consider having a pre-conference meeting with the interpreter to review topics to be discussed. Speak slowly, use shorter sentences, and decrease the number of words per utterance. It is always a good idea to ask families, even English speakers, to repeat back what they understood to make sure key information is relayed. In summary, cultural competency is an oxymoron in that we are never truly competent. Cultural understanding demands ongoing learning because culture is multiple, dynamic, and complex. The goals to strive for are a desire to learn about a patient's cultural experience and a constant, strong commitment to provide socially just health care. I'm sure there will be lots of discussions about this topic, and I look forward to your comments in our question and answer session. Thank you for your time and attention.
Hello to all. My name is Dr. Ebony Jade Hilton. I'm an associate professor of anesthesiology and critical care medicine at University of Virginia. And I'm here today to talk about teaching cultural competency in critical care and why it actually matters. And the reason why I think this is so important is that we oftentimes have a patient that lands in our ICU that cannot speak to us. But how do we get to understand, based on this person's lived life circumstances, what actually landed them? What helped to create the situation that landed them in our ICU in the first place? Because we know that if we do not treat this patient holistically, then we're not doing the best service for them. So here we go, and I hope you enjoyed this. I first have to disclose that I am the co-founder and medical director of Good Stock Consulting, and we really do try to approach disparities in all industries, agnostic to industry really, to address what are the factors that lead to worse outcomes across the board. Now, as another disclosure, this is me, and it's not my attempt to be narcissistic, but it literally is just to say that I am Black. But this is also me. This is my 23andMe report, which shows that I'm basically like the walking United Nations of person. And I did that. I donated my DNA to find out, for one, who am I and where do I come from, but also to be able to say that I come in peace. That when we're talking about things like race, religion, gender disparities, oftentimes that can be a us versus them mentality, but I truly don't approach it that way. I think that we are all a collection of different persons, and that if we start to approach this from a center of love, then we can actually start to move this needle to make sure the disparities can actually end with our generation. So let's start. What is this topic of cultural competency, and it's in particular one that gets the most attention, that of race? Is it important? Well, we know it's listed on literally your birth certificate before many of us even have a name, but does it matter? Well, according to the Human Genome Project, the answer to that is no. In 2003, the year before I started med school, this project was completed and stated that all human beings, regardless of race, are more than 99.9% the same. And so my question was, when I started medical school, then why am I asked to introduce a patient as a 36-year-old white male or 42-year-old Black female? Does that qualifier matter? Well, according to Dr. Cameron Phillips-Jones, who is an epidemiologist out of Atlanta, she says that the variable race is only a rough proxy to define one's socioeconomic status, culture, and genes. It is not a biological construct that reflects innate differences, but a social construct that precisely captures the impact of racism. And it's for this reason some investigators now hypothesize that race-associated differences in health outcomes are in fact due to the effects of racism. Now, I don't know about you, but in this moment, I read this in my 20s and I was thinking to myself, you mean I just literally donated my life and sacrificed my life in order to become a part of a system that would discriminate against my own people? And according to Dr. Jones, the answer to that is simply yes. And it's because of the downstream impact that race has on health outcomes. And we can think about biological factors. Just what regions do you grow up in that predominantly those we call Black and those we call white tend to have the same disease process like sickle cell anemia versus cystic fibrosis? But we can go deeper. When we're thinking about cultural impact, shouldn't a white man and a Black woman in a deep South subjected to the same high fat, high cholesterol diet have the same disease process outcomes? Or if we're thinking about economics, shouldn't a poor Black person in Mississippi and a poor white person in Minnesota have the same outcomes? Or what about politics? Regardless if you vote Democrat or Republican, if it's a policy, shouldn't it broadly affect all of us at the same rate? And she says, again, the answer is no, because again, the downstream, what happens at the provider level? What's the implicit and explicit bias there? What are the stressors associated with being a minority in a majority, society? What are the impacts of environmental racism and industrialization of certain zip codes? Or what about the lack thereof, the hospital deserts that exist within zip codes? And how do all of those culminate to be what we see in poor health and health outcomes? Now, at this point, I started to think to myself, okay, what if we're saying that what you're saying is true, Dr. Jones? How big of numbers are we actually talking about? Well, we can look at the life expectancy from birth by race and see just how big of an impact it truly does have. So this is for Black males, white males, Black females, and white females. And you see, this is from 1970 to 2015. It was only till recently that Black men started to reach the life expectancy of white males. We're reaching back in the 1970s and 1980s. Now, this is despite advancements in diagnostic test capabilities and therapeutics. And we see, unfortunately, even before the pandemic, we saw a slight decline in the life expectancy that Black men could anticipate reaching. And we see it was well below 70. And that, to me, it left me with this deep question of why is that? And I'm not alone in that. Dr. Martin Luther King, this is back in 1966, said, of all the forms of inequality, injustice in health is the most shocking and the most inhumane. And my question for us is, this was 2 years before he was assassinated, and it's been 55 years since. Have we changed as a medical entity? And have we moved this needle towards keeping people as healthy and happy and prosperous as possible? Well, I think nothing has kind of highlighted that we have still a long way to go than COVID-19. And in fact, if we're looking along racial lines, 1 in every 353 African Americans has died since January of 2020. 1 in 6 of those of Black people who have died from COVID-19 was actually less than 55 years old. And there's this constant rhetoric of it's only the old people who suffer. That's not true for us. And it's not just not true for us who unfortunately pass away, but it's those people who are left behind, because you see there's 175,000 orphans now. 1 in every 4 COVID deaths resulted in an orphan, and 65% of those have been racial minorities. And this study is actually was a couple months ago. So we now have an additional, I think it's now 200,000 orphans, and they continue to be heavily racial minority children. Black children are still 5 times more likely to be hospitalized. Again, age is not protected for us. And then 1 in every 4 children who's been less than 18 years old that has died from COVID-19 has been Black. 64% of all children who's died from COVID have been racial minority children. And if Black people died at the same rate as white Americans, 16,000 of us would still be alive today. Now that's a huge burden. And we have to consider, well, why is this happening? Again, what happens before you end up in the grave or before you end up in our ICU that leads you to have a higher rate of infection with COVID-19 and a higher rate of complications associated with that disease process? And we know why the higher rate of infection, right? When we had this shutdown of our society, there were certain groups of persons that were forced. They were not able to do Zoom work and be protected in their home. They were those superheroes that we call essential workers that literally are fighting for a livable wage, but were expected to go out into society to keep our nation afloat. and we look at the demographic of those persons who have to go out and expose themselves to COVID-19 when we did not have resources to protect them, we can see that they were largely Black and brown. And this graph is just showing who exactly lives where and works where. So if you're looking at this grayed out area, those are the managerial positions. Those are the people that were able to stay at home in their Zoom calls and be protected. It's these colored blocks here. These are the persons in production and sales and in service industries. And we can see that the Hispanic Americans and African Americans make up a large proportion of those persons who were forced to go out. And it's not only just location wise, it's also what money did they have to say that if I have an outbreak in my job, I can simply say I don't want to go because I have money that I can fall back on to say I can still pay my bills, I can still keep food on my table and provide for my family. But if we look along the lines historically, there's always been a gap in the income earned for along the lines of race. In fact, you see Black women, Black men, white women, and white men, and this is income by week from 2000 to 2020. So you see, this is not something new, but historically there has always been a gap. In fact, you can have a higher educational attainment and make less money than a person who has less educational attainment who happens to be white in that same position. That's the way that we've historically been and continue to be today. And it's not only in income, you're fortunate if you have income, if you're African American, because this was February 2020 to April 2020. And we see in the beginning of the pandemic, we already had higher unemployment rates. But by April 2020, less than 50% of all Black adults actually had a job. We're the first ones fired and the last ones hired. And it makes an impact. In fact, if you think tangentially as far as what income looks like, for every dollar of income that white Americans make, Hispanic Americans make 72 cents, Native Americans make 62 cents, and African Americans make 59 cents. And income is one thing, income is great, but wealth is an entirely different thing, because with wealth, I could be able to say, if there is an outbreak, then I have enough savings account, I have enough cushion, equity in my house that I can fall back on to keep myself out of that dangerous situation and be able to provide my own self for protection. I can still feed my family. But what we see as far as wealth, for every dollar that white Americans have, Hispanic Americans have 12 cents and African Americans have 10 cents. And we can go through the impact of the Homestead Act and the Social Security Act and the GI Bill and the historic welfare programs that were created for white Americans in the 1800s that allow for them to accumulate these generational wealths and the passing of land that Black Americans were completely shut out of and have been suffering from since. In fact, it's an estimated of 250 years before we'll be able to close the wealth gap that is associated along the lines of race in the United States of America. And it's not only just in terms of what I can buy as far as food, but it's also, we know that your money also determines where you can actually live. And we can look at the historical impact and the cultural impact it has with racism in redlining. So redlining was literally where lending industries would take a map and outline where they wanted populations of Black and brown people to live versus white people. And at this current stage, you can literally look at the outlinings of the highway systems, and it gives you an idea of where those pockets of Black and brown people were allowed to locate, because those are where you see the high urban density, right? And you see this high density population, and what does this do during a time of pandemic when you want people to socially distance? You can see in those same zip codes, you have high industrialization, and what does this do? You can think about Flint, Michigan, for instance, but what does this do when you have air pollution and water pollution? What does that do to the development of asthma and chronic lung disease, for instance, right? And the development of cancers. When you're looking at it, you can also see food deserts where literally there's no healthy food eatery or grocery store within miles, but instead you have McDonald's, Taco Bell, Burger King that is planted within that community. And what does that do to the development of hypertension and diabetes, right? And then you also have this insult of poverty. And when we're thinking even now with the influence of schools and the infection of children, we have to think that school resources and fundings come largely from local property taxes. But what happens when you cannot afford to own your homes and the homes look like this? That means the schools are underfunded and they're overcrowded, and they lead to a greater infection with our children. And it's a great problem, because what we know is that if you eliminate segregation of housing in itself, you can erase Black-white differences in income, education, unemployment, and reduce differences in single motherhood by 66%. And it's not because all of a sudden with this gentrification that white people bring a better character. It literally is just that when white people move into that area, money follows it, and that the local and state governments send money to now create and eliminate food deserts. They clean up the air and water quality, and it leads to an overall better quality of life and therefore quantity. But when you're in those environments that have that lack of, what does it do to the body? And we know this as physicians, that it does cause a surge, right? When you have that constant fight or flight, we have the cortisol, the glucagon, catecholamines that are released. And we know the end organ insult or tachycardia, vasoconstriction, of retention of sodium, of gluconeogenesis, of decreased insulin sensitivity. We know it is bad. And this study showed that chronic psychological stress of trying to fight or flight and trying to survive leads to hypertension, it leads to diabetes, it leads to obesity. It literally ends up leading to increased malignancy and likelihood of metastasis of cancers. And this was an interesting study that shows that it actually, if a mother is chronically stressed before she gets pregnant, she's more likely to bury her child once she is actually pregnant before their first birthday. And that lends itself to make you question, is that why we're 2.5 times more likely to bury our child as Black women? Because of this insults of society. And it's not just the community level insults that we have to face. We also have to deal with understanding the cultural implications of being Black or brown in society when we are approaching medicine. This is the Virginia Department of Health that was looking at COVID-19 related ER visits. And what they found was that Latino Americans, then Black Americans, and then white Americans were more likely to visit with signs and symptoms of COVID. But they went a step further and said, okay, you visited the emergency department, but who actually was hospitalized? And what we saw is that white Americans were more likely to be hospitalized, followed by Black Americans, followed by Hispanic Americans. And they made a very interesting comment at the bottom of this chart, so interesting that I decided to highlight over here, where it says, despite their best intentions, health providers may take complaints by white patients more seriously than complaints by people of color. And I don't know if they meant that as a way to pacify the insult, but I don't need an explanation of why. I need you to fix the problem, because we know doing that, having that bias costs lives. In fact, in New York City, this was a study looking at what happens to Black and white patients once they're admitted to hospitals. And what they found was that Black patients were more likely than white patients to test positive for COVID. They were more likely to be infected, but after hospitalization, they had a lower mortality rate, meaning that if you allow these people to come into the hospital and actually be afforded the luxury of being treated, that you could save their lives. And that's what we need to kind of address. What happens once a person gets into our hospital? And it's not only the types of things that happen within the hospital walls, it's policies that we have put out that are also rooted in racism. For instance, if we look at vaccine allocation, we have phase 1A and phase 1B and phase 1C that attain the vogue words. But if we look at it, during a time when we had racial health disparities where you're 5 to 7 times more likely to die if you're Black or brown, when we prioritize who should actually be vaccinated, we went to the phase 1A groupings, which were healthcare workers and long-term care facilities. So if you look at healthcare workers, 60% of us are white, 16% of us are Black, and 13% Hispanic. If you look at long-term care facilities, so for one, long-term nursing homes, we know that the majority of persons that live in nursing homes, they have to pay to do that. We've already talked about the gap in wealth that Black Americans have in particular. But also, there's a luxury of being able to grow old. Again, we talked about life expectancy and the truncation of that for African Americans in America. And what we see is that for nursing home residents, 78% of them are white. In fact, if you look at for age group 65 and older, we're looking at 77% of all Americans who are 65 and older are actually white, okay? When we went to phase 1B, we then said high-risk persons. So we said 75 and older. And again, I just showed in the previous graph in the life expectancy that Black men were not even expected to reach the age of 70 back in 2015. So that largely excluded them, although we know they were the highest rate or risk of dying from COVID-19. The other qualifications were pre-existing conditions and then employment. And again, I stated that Black people, unfortunately, by April 2020, less than 50% of all Black adults actually had a job. So basically what we told Black Americans, in order to qualify for phase 1A and phase 1B prioritization, even though we know there is a racial health disparities where you're dying at younger ages and at higher rates, we told you that in order to qualify for this life-saving intervention, that you needed to have come into 2020 with at least one of your organs already dead and dying. You needed heart failure, you needed renal failure, you needed a cancer, you needed diabetes. But we said to white Americans, you just needed to simply be able to live to a lifelong age. And you also just needed to keep a job that was your only qualifiers. And it is not only what qualified as far as the prioritization of vaccines that we have to talk about, we also have to talk about the locations by which we place these life-saving interventions. In fact, hospitals, we know there are hospital deserts within our communities. In fact, you're twice as likely to not have a hospital if you're in a Black community. But also we can think about when they said we're putting these in pharmacies as well, as if that was a win. But what we know is that 73% of all ambulatory care facilities and pharmacies are in predominantly white communities. They are not in our community. And this all culminated initially when the vaccines first rolled out. We heard how, oh, there's vaccine hesitancy with the Black community. That was the label that was thrown on us, even though we knew largely, as far as prioritization, even if you wanted to be vaccinated, you could not be vaccinated as an African American because you were not included in those prioritization qualifiers. But we also saw, though, before phase 1A, phase 1B, that was up until March and leading into April. By May and June, that's when the general public now were able to experience this luxury of being vaccinated. And what we see, this is the circles here, the Black, the African Americans. We see that there was a sharp incline because there was not a vaccine hesitancy as much as there was a vaccine denied and a lack of access that we had to contend with, where we had literally our vaccines in barbershops and in grocery stores because we did not have a facility by which to store them. And we see that at this point, our uptake has now started to match that of white Americans. On a large scale. And that is, again, despite the fact that we don't have ready access to these interventions and that we don't have primary care physicians and we don't have those resources within our community. We still overcame that. And it's important. The reason why these things are talking about how the structural racism plays into why we don't have access, why we have the insult of comorbidities being placed at our doorstep is because Black Americans, if we're looking at what the incidence of disparities in every single age group, we had higher death rates in at younger ages in every single age group. So the tall bars here, the dark bars, are going to be African Americans and Hispanic Americans. And you see across the board, regardless of age, we were always more likely to die from COVID. In fact, by December 2020, when I received my first vaccination, African American women my age were 5.6 times more likely to die from COVID-19 than their white counterparts. And for African American persons that lived to see the ripe old age of 85, 1 in every 56 of them had died. At this stage of the pandemic, that number is now 1 in every 5. We're losing entire generations to COVID-19. And we see this, right? That there was a sharp decrease and decline in the life expectancy of Black and Brown Americans in ways that we have not seen before. And how steep? Well, if you're an African-American male, in the first 6 months of the pandemic of 2020, we see that African-American males lost 3 years of life expectancy, followed by Hispanic males, followed by Black females, Hispanic females, white males, and Hispanic are white females. In fact, when you think about this intersection of race and gender, oftentimes you hear this statement that women do better than men in terms of COVID outcomes. But if you're a Black woman, you are, again, 3 times more likely to die than a white man. The intersection leaves us as silent victims, oftentimes because race trumps gender, race trumps socioeconomic status, race trumps so many things and leads to worse health outcomes for us because, again, of the insult of policy, person, place, and politics that follow and impact a person's overall health outcome. And it's not only just about that, we have to think about the other end of the spectrum when we're talking about cultural competency is what happens with white Americans too. They also have culture, right? They also have a shaping of America. And unfortunately, we're seeing this introduction of politics and the influence of politics on health. And it leads to this discussion that we have to have with white Americans too, that's landing them in our ICUs at higher rates now towards the end of the pandemic, although we have higher and more available resources to keep them out of our ICU and protect them from COVID-19. And this is just an example. This is looking at white Americans only and the number of deaths that we had in 2020 from September, October, November. And you see after the election, something very interesting happened after the election. Is that we went from 14,000 white Americans dying to 27,000. After Christmas, we went from 27,000 to 42,000. After New Year's and Super Bowl parties, we went from 42,000 to 47,000. And between February 2nd to March the 2nd in 2021, we had 58,000 white Americans die from COVID-19. Now, this is despite us now having vaccines. This is despite us now knowing that masks that N95 masks work and are now readily available to the public. So this was largely driven by behavioral choices of what we choose to do that has led to this insult, and has narrowed the health disparity from you being 6 to 8 times more likely to die if you're Black versus white to now being 2 times more likely to die. Not because Black people are dying less, but because white Americans are dying more. And so it's just one of the things that we have to consider. You know, I would wrap up this presentation by saying what, you know, my teacher, James Baldwin, said: I love America more than any other country in this world. And exactly for this reason, I insist on the right to criticize her perpetually. And that's how I feel. I absolutely love America, and I love our medical institution. And what we have to do is start thinking holistically of how are we impacting persons' lives, not only once they land in our ICU, but are we addressing everything holistically that literally impacts their life from the time they are born, from before they are conceived, and to the moment that we actually have the privilege of being able to take care of them. And I do think we can do this. You know, we think about disparities in 3 different buckets: the individual, the community, the hospital, right? Things that we have advocates that are individual advocates, and we have public health, you know, facilitators that say this is what we need as far as community resources. We have clinical advocates like we are, right? But I think what we need to really think about is, do these 3 ever talk to each other? Do we use the same language? Do we understand what's actually happening to the individual and in the community level so that we can impact outcome and we can actually move the needle on disparities that face us today? So I thank you all for joining me, and I look forward to any questions that you may have.
But thank you so much, everyone, for joining us. I also wanted to thank all of our presenters, including Dr. Moitra, Dr. Liu, and Dr. Hilton, for their excellent presentations and insight. As our speakers have pointed out, this topic is more relevant than ever in our multicultural society and a more globalized world, especially as the delivery of effective, culturally safe care can alter our healthcare outcomes. So with that, I'll open the session up for any audience questions. You can put them in the chat, or you can unmute yourself and ask the questions to the panel. Don't see any questions right now, but one of the questions, you know, after reviewing the presentations, you know, you guys had alluded to cultural competence being misconstrued as mere understanding of cultural norms and the sensitivities of a community. And as you mentioned, it's much more than that. And cultural competence is often projected as a finite process. Compared to cultural humility, a lifelong journey of self-reflection. And for many organizations, cultural humility or cultural competency, training fulfills specific requirements. So with that, you know, do you think an approach to cultural competency that focuses on acquiring just knowledge is problematic, because it suggests that competency can be fully achieved through this static process? And if so, you know, we'll be creating practitioners who have a false confidence by going through these, you know, 1 or 2 courses. And should we do away with these courses, and how should we implement, you know, this notion of cultural humility in healthcare?
Well, maybe I'll start and then other people can chime in. I think it's important to at least start the dialogue and to at least set aside time in our curriculum and in our busy day to think about the concepts. And it's almost like cultural competency 101 and then move on to cultural humility 102. It's a lifelong journey. And before we even started these topics, I don't think physicians had a lot of training in it.
I think it's a philosophical question in many ways, Babar. You know, it's hard enough for physicians to say, I don't know about a physiologic process. I think we're getting closer to it for that low bar of saying, maybe I'm confused about what's going on with this patient. But I think we need to start to be humble enough and have the humility to say, I may not know this patient. and I got to be curious, and I got to ask for help. The way to do that is to model that, to role model that. And it's got to be integrated into the fabric. I do not think an online module of any kind is going to solve this problem.
Yeah, I kind of agree with that. I think what I was trying to push in my lecture is to show that this actually does have life consequence, right? And that's not understanding the holistic approach of what shapes someone's culture, but then also how does society feel about that culture, right? And what are the impacts of systemic racism that leads to outcomes? And if we as physicians, I do feel like we should be the smartest people in the room, and that we treat people. And so, one of the things that I think needs to happen is accountability metrics tied to it in our outcomes. How are we looking at our policies again and protocols that we put in place within the hospital? Do they truly reflect, again, what the impact of one's culture on their lived life experience, right? Where they eat, where they sleep, where they pray and play. Do our protocols reflect that? Are we adjusting our protocols to provide equity in everything that we do?
That sounds great. We have a question from Dr. Hayhurst. She said, thank you all so much for excellent presentations. How do you approach highlighting the disparities that exist, as Dr. Hilton demonstrated, that exist for our patients in your real-time bedside teaching?
I literally, one of the things I love to do is talk to the patient in the ICU, it's kind of difficult to do that sometimes, but talk to their families and have every round. I have that within the patient's room. Sometimes you see people standing outside, but it's like, let's actually get in there and talk to people, ask them, what is it that led you here in the first place? So we can hopefully keep them out of our ICU the next time around, right? And just truly, I think developing relationships, even amongst ourselves. I think in medicine, we become so sterile in our approach to talking to people. How many of us actually know our coworkers? How many of us invest time in getting to know our residents and our med students to say, just like, what is your experience that doesn't come from a book, right? That can't be taught. Teach me something. And I learn something new every day, just from interacting with mainly my patients' families, but asking, questions. If someone has a different religion than me, then unfortunately, when people pass in the ICU, I want to know what is your cultural, norms. How am I supposed to treat you as you transition, to make sure that I'm doing the appropriate things and being as respectful as possible? And asking that question for one patient who was Muslim, I found out our hospital does not have, we only have a Christian pastor on staff. And it took an arm and a leg to try to find someone within the community that could come and do the rite of passage for this patient. And those are the types of things that shouldn't still exist in 2022, but here we are. So I think being inquisitive to not only understand what's physiologically wrong with the person and how can we give them medications and drugs, but it truly is like, who are you and how can I best serve you in that way?
I can add two examples, one from COVID. I think at the bedside, we can just highlight visitor policies, just make some observation on who gets exceptions to policies, and see if you notice any patterns or themes in your particular ICU. I think that can be enlightening. And I actually think, when we do our assessment and plans of each patient and we talk about how much pain they're in, try to listen to your team and figure out whether or not the pain assessment is objective or subjective. And figure out, why people will say, oh yeah, I don't think they're in pain. And how do you know that? Are we using sort of quantitative measures to do that, such as NRS or CPOT? Or are we just looking at a face and say, oh, they look stoic, they're comfortable, I assume they're not in pain? It's really low hanging fruit to try to point out some opportunities.
Great. I think I have two more questions based on those observations. As you mentioned, an essential component of, promoting inclusive environment is a diverse workforce. So what methods have you employed to encourage diversity in your workforce, especially when it relates to trainees and their acceptance into residencies or fellowships, in order to build a pipeline for the future? For me, when I look at an application, it used to be SF Match will have the picture of the individual as like the first thing that will show up. And then they changed it where, once you hit accept for interview, then you still see the picture, but the picture still comes. So what methods have you used in your practice to eliminate those kind of biases?
I can tell you what we've done. We redact all our fellow application, the USMLE scores. We redact the name of the residency. We redact the name of the medical school. We redact the name of the logo of the letter writer. We redact the letter writer's name. And we're left with personal statement, activities, the content of the letter of recommendation. And what we have learned is how similar applications are when you do that. So our bias is like, oh, they come from so-and-so, and I know this person, they must be good. Our experience has been that isn't always true. So we've just done away with it.
I will also say we try to reach further back to get to some of these applicants before it's time for fellowship. So we're bringing them into our department in high school, in college, to just check out anesthesia as a field and follow some of the critical care physicians around.
And I think it's also important to, again, because we know there is going to be a lag in the diversity of departments, right? Every place I've worked, I've been the first and only Black female anesthesiologist. And so if you have that lack of diversity, it's up to you in the department to learn and push yourself to learn about people that don't look like you, that you don't have within your group. I think that's extremely important. And it's one of the things, like for instance, the other day, I truly do feel like I do a disservice to my patients that don't speak English, right? I feel it in my soul, like I can't talk to you, and it bothers me. So one of the things I thought to myself was, then why don't I learn? And I've tried to learn, and that part of my brain doesn't work well. But I pitched it to our group and asked the residents, is anyone interested in doing a QI project of where before grand rounds, you teach us one or two phrases, and over the course of years, and yes, it's only one or two phrases, but over the course of years, maybe we can start to develop some form of being able to communicate in Spanish, right? Of commonly used phrases within the operating room. And there was someone who knew Spanish. So it's like, okay, that's an easy win. And just trying to think, outside of the box and really push ourselves and not say, well, since it's uncomfortable for me, and since I have difficulty doing this, I'm just going to say, I'll just call on a telephone and figure it out that way. We don't have telephones in our operating room when the patient is waking up. And if I am speaking to an English speaking patient and I want to relay information, I should be able to do that with every patient. And I may not be fluent by the end of this year or the next year, but at least I tried. And I think that's important for all to know, that it's okay to fall short, but as long as you're trying to improve every day.
Sounds great. Thank you so much. I think we have one more last question for Dr. Oliveira. As a follow-up, what strategies have you found most successful to navigate the often encountered defensive response when a potentially bias-driven behavior occurs in clinical practice?
Well, my approach is always head on. I had the diversity and inclusion officer of our university, brand new, and he called and had an interview with me, and he was like, well, how do you think we should talk about like systemic racism or practice? I was like, well, I think you should just say that. Is it in medicine, we don't tiptoe around diagnosing diseases, right? We call it what it is. And until we start to call things out for what they actually are, then we can't actually fix the problem. And that's why I do truly believe why we see the disparities across the board that have been there for generation after generation, because we are good people are too afraid to just say it, right? But it shouldn't be something that we're fearful of. And oftentimes I do feel like most bias is probably implicit, right? People just not really thinking of it. But if you bring my awareness to it, now I have a potential to be able to do something about it, right? And so, so I call a spade a spade. I do it often, and I think once that conversation is opened up, it makes other people more comfortable in speaking up too, right? Yeah. So.
Great. Any other questions from the audiences? Anything else from our panel? Thank you so much, everyone. Thank you for joining us. Thank you,
Thanks,
everyone.
everyone.